Hi, my name is Courtney Wu, and I am a Master of Science candidate at the University of New England. Today, I am very happy to present my defense of my Applied Nutrition Capstone project entitled The Elements of Effective Group-Based Diabetes Management Education Programs. Before we begin, I would like to review the presentation outline for today. This includes the introduction of myself, including my education and experiences, a background and research question outlining the nature of the study, methods, data, and results of the study, as well as the discussion of the findings, and the overall conclusion and future implications of the study. A little bit about my background. I am a registered dietitian, and again, I'm a Master of Science candidate. I also hold a graduate certificate from San Francisco State University, where I completed my dietetic internship. I also have a Bachelor of Science in Dietetics from Point Loma Nazarene University. In regards to clinical experience, I currently work in skilled nursing, and I also have work experience in outpatient counseling as well as inpatient care related to eating disorders. My current nutrition interests include diabetes care and the gut microbiome, but today we are here to primarily discuss diabetes care as it has been one of my passions for several years now. During my undergraduate college experience, my best friend and roommate had type 2 diabetes, and that spurred my interest to continue studying the care and management of those with diabetes. I also hope to become a certified diabetes educator in my dietetic career, and I hope that this information will continue my learning experience, but also provide me with knowledge to use when I eventually attain that goal. A brief background about diabetes. It is widely known that diabetes condition is widely prevalent across the United States and the globe. It is estimated that 1 in 2 people, or 46%, who have diabetes are actually undiagnosed. In another report conducted by the Centers of Disease Control and Prevention, estimated that diabetes was the cause of 5 million deaths in 2015. Diabetes management and treatment and the complications associated with that have been noted to cause an increase in healthcare costs as well. Therefore, there is a need for exploration of alternative treatments for those with type 2 diabetes. This is a glimpse of diabetes healthcare costs. In 2010, it was noted that $376 billion was spent on diabetes in the world economy. And as you can see from the image on the left, there is an increasing trend of increasing healthcare costs over the years related to diabetes. Currently, the forms of treatment for those with diabetes include medication, insulin, lifestyle education, and other forms of education. In relation to programs, group programs are now a popular form of education, and they have been shown to improve glycemic measures, which is one of the primary outcomes for those who have diabetes. Additional studies have shown positive effects on clinical, lifestyle, and psychosocial outcomes in those in the intervention groups who receive the group education. Group programs are also cost-effective forms of treatment for those with diabetes. Therefore, this fact may increase the accessibility of those who attend these group programs because they may not be able to afford individual sessions by a registered dietitian or other health professional. Considering all the forms that group education could hold, such as face-to-face and telephone, or virtual methods, this begs the question of what are the effective factors of group education for those with diabetes and what will bring the best results. This brings us to the research question at hand, and a systematic review of the evidence was conducted to find the qualities of effective group-based diabetes management education programs on glycemic measures, including fasting plasma glucose and hemoglobin A1C in adults with type 2 diabetes mellitus. Here is the beginning of the methodology for this review, starting with the selection criteria. I have listed the inclusion and exclusion criteria in the tables pictured here, but one of the highlights that I would like to discuss about the inclusion criteria is the age range selected for this target population. I selected the age between 30 and 70 years old, and the reason for this is that because there would likely be a lifestyle and life experience gap between those who are 18 years old compared to those who are 70 years old. One of the benefits of group education is the peer support and connection with those in the group, and this would likely be difficult with those who are 18 comparing to life experiences of those who are 70 years old. Another highlight is the setting of the and health status of the target population, which is community living and free dwelling, and those with type 2 diabetes who are non-hospitalized. And this reason for community dwelling or free living individuals is so that they are able to attend the group sessions. Another highlight of the inclusion criteria is the study design preference, which is clinical trials and randomized controlled trials, which is the gold standard of research studies designs. Studies will then be excluded if they contain populations with the age range outside of the inclusion criteria, if they are in an inpatient or acute care setting, and if they have a diagnosis of pre-type 1 or gestational diabetes. Study designs that will not be considered for inclusion will include cohort studies and other criteria relating to the intervention. The studies that contain interventions with telehealth or individual counseling will not be considered for this systematic review. Moving on to the search strategy, I, as the sole investigator, utilized the databases PubMed and ProQuest Central to conduct the literature search. I used various combinations of the search terms as displayed on this slide, including type 2 diabetes, group education, group management, DSME, short for diabetes self-management education, glycemia, and glycemic. On the right, you see the Prisma flow diagram, which shows the record identification process through the screening and exclusion to result in a total sample size of 4 randomized control studies. Once each of the studies included were identified, the studies were then reviewed for quality based on the Academy of Nutrition and Dietetics Evidence Analysis Library checklist for quality criteria of the article. The first randomized control trial that I will review was conducted by Elia et al. And published in 2013. This study was conducted in Iran with the purpose of examining the effectiveness of group education and nurse telephone follow-up in controlling blood glucose and increasing adherence to treatment recommendations. The quality based on the evidence analysis library checklist was of positive quality. The intervention they were testing included 2 60-minute face-to-face group educational lecture sessions in consecutive days about diabetes complications, self-care in diabetes, insulin management, and self-monitoring of blood glucose. This was in comparison to the control group who received conventional treatment, and the study period was over the course of 3 months. Primary outcome data was in relation to glycemic measures of hemoglobin A1C and fasting plasma glucose. The results demonstrated that a mean difference in hemoglobin A1C in the experimental group was significant, and the change in fasting plasma glucose also reduced in both the experiment and the control groups. The authors concluded that results showed that group education demonstrated improvements in glycemic measures and adherence to treatment recommendations in adults with type 2 diabetes with the nurse telephone follow-up. They concluded that both hemoglobin A1C and fasting plasma glucose levels improved in the experimental group after the intervention. The second randomized control trial was conducted by Mash et al. And published in 2014. The study was conducted in Africa, and the purpose was to evaluate the effectiveness of group education led by health promoters for people with type 2 diabetes in community health centers in Cape Town. After a review with the Evidence Analysis Library quality checklist, this randomized control trial received a positive quality. The intervention in question was a 4 60-minute session of group education about diabetes, living a healthy lifestyle, medication, and complications led by the community health promoters. This was against the control, who received the usual diabetes education that was typically given at the health center. This study period was over the course of 12 months. Primary outcome data was hemoglobin A1C, and the results revealed that there was no significant difference between the groups in reduction of hemoglobin A1C levels by 1%, which was their outcome of question. Therefore, they concluded that there was no significant effect of group diabetes education on glycemic measures or reduction in hemoglobin A1C after 12 months. Their additional outcome measures in question, including systolic and diastolic blood pressure, showed significant differences between the groups after 12 months, revealing other clinical measures that should be assessed for those who have type 2 diabetes. The third randomized controlled trial was conducted by Torres et al. And published in 2018. The study was conducted in Brazil with the purpose to evaluate the effect of diabetes mellitus education program in primary care on glycemic control. The Evidence Analysis Library checklist revealed a positive quality study. The main intervention in question of this study was group-based education regarding healthy eating, physical activity, feelings that may impair adherence to self-care practices, and goal setting over the course of 3 2-hour sessions once per week for 3 weeks. The sessions were led by a nutritionist and a nurse who also conducted follow-up phone calls. This was in comparison to the control group, who received educational practices developed in the respective basic health units and also received the conventional follow-up. Measures for hemoglobin A1C were taken at baseline, 3 months, 6 months, and 9 months, which was the conclusion of the study period. The results demonstrated that at 9 months, the mean hemoglobin A1C of the intervention group was statistically lower than that of the control group. However, the results and conclusions indicated that the group education contributed to the maintenance then reduction of hemoglobin A1C versus the control.